welcome back to another episode of MedSynapse podcast series. I'm your host, Shah, and today we are diving into an important and evolving topic, which is metabolic health and the modern women, unpacking PCOS, insulin resistance, and beyond. So, we all know that PCOS has been thought of as a reproductive issue, but recent science tells us that it's much more systematic metabolic disorder with long term implications for diabetes, cardiovascular health, and women's quality of life. And let's break this down step by step by none other than Dr. Chetan Purad. So, welcome, Doctor, once again, who is the director at Arman, a results driven leader with the fellowship in diabetology. Dr. Purad brings deep expertise both in endocrine and metabolic health, and we are so excited to hear about this topic from Dr. Al. So thank you, Doctor, for joining us again.
It's a pleasure to be here again any day. Thank you.
Doctor, let's start with the foundation. Like PCOS is now considered a systematic metabolic disorder rather than just a reproductive condition. So can you walk us through the key mechanisms linking insulin resistance, hyperandrogenism, and inflammation in women with PCOS?
Right. So PCOS, which actually stands for Polycystic Ovary Syndrome, and like the name suggests, it's a syndrome which is basically beyond a step further than the disease. It means basically that there are different components at play in multiple presentations and multiple organ systems. So what exactly happens in this PCOS is basically, if you look at the way the components of the axis, or what we like call it as hypothalamus pituitary ovary axis and hypothalamus pituitary androgen adrenal axis. If you look at this, then one of the major reasons is that the pituitary releases something known as GnRH, gonadotrophin release hormones, right? And the hypothalamus releases that, and the pituitary in turn releases the luteinizing hormone and the follicle stimulating hormone. And they have their functions. The follicle stimulating hormone prepares the ovary, and then androgen generation and all that, whereas the luteinizing hormone produces excess of estrogen conversion to androgens. So the one mechanism is that there is a lack of this negative feedback to the axis, both at the hypothalamus level and the pituitary level, which is asking them to stop the production of gonadotrophic releasing hormone. Now, why this exactly happens is not very clear, but it is being considered to be multiple factors in association with it. Majorly it being a genetic component to it. But now recently we have seen, and there's significant evidence of it, that by and large the genetic component gets overridden by other choices which young women make, for instance, their lifestyle, their diet, their sleep. All these factors directly or indirectly contribute to that. This condition has two major things. One is there's an excess of LH or luteinizing hormone, and then there is hyperinsulinemia, which is an excess of insulin. Now, to answer this question, what causes first, how did they start, will be a little tricky. But if you see, the excess in LH is released by the high frequency of or higher pulsatile nature of GnRH. GnRH gets released in pulses throughout the day, not in single thing. So if this frequency for some reason is on the higher side, then there is a more of luteinizing hormone which is produced. Now, luteinizing hormone per se is responsible for the secondary sexual characters, but in this case, what it will do is it converts the estrogen present or developed by the follicle stimulating hormone and the interstitial cells into androgens. Now, these androgens are essentially testosterone and its derivatives, which add to the symptoms and signs which normally the PCOS woman has, which are basically male type of balding pattern, excessive hirsutism, hair growth, acne, and things like that. What it also does is, in turn, either directly LH or through the mechanism of testosterone, is to bring in a sense of insulin resistance. So normally the insulin, at whatever proportion it was supposed to act, will now need more insulin. One of the major effects of insulin is weight gain. So this weight gain, insulin, and then androgens are in continuous cycle formation, which continues to do that. Hence, this is how the mechanism is established, and obviously, it leads to other symptoms like amenorrhea, weight gain, hirsutism, hair loss on the head, and things like that.
Correct. Yeah. So I think a lot of different uh, diseases and comorbidities is interlinked with PCOS, if I'm not wrong.
Correct.
So now, doctor, talking about lifestyle intervention only, so the new 2023 International PCOS Guideline update really emphasizes lifestyle interventions as the first line of care. So, based on evidence, what specific dietary and exercise prescriptions have shown the best results for improving metabolic outcomes in PCOS?
I think that's a very important question because we may diagnose a disease, but how do we manage it? First of all, we need to remember that PCOS by and large medically does not have a cure as such, or there is no proper treatment. In other words, we can look at addressing those components which is either a byproduct of PCOS, which will cut the vicious cycle which I just mentioned, and also take care of all those contributing factors, in addition, not mentioning the genetic one, which are contributing to this. So broadly, we can look at it as a three-component or a three-pronged approach. One is a lifestyle change. The second one is, like you said, dietary. I'll dwell a little deeper into all these three. And third one is pharmacology. So starting first with a lifestyle change. So when you see typically adolescents and young women who have this condition are one, having disturbances in their sleep cycle. Nowadays, we see that people spend a lot of time on their phones and the sleep cycle is entirely disturbed. It is known that sleep cycle is one of the trigger factors for a high pulsatile GnRH release, which in turn leads to all the cascade which we described for PCOS. The second one is sedentary lifestyle, lack of exercise. So this again will lead to insulin resistance, obesity, and most importantly, what we see is what people consume and what type of food they consume. So what they consume is inherently related to the intake of calories. So the higher intake of calories with lower, expenditure of those calories will lead to again the adding to the vicious cycle of obesity, hirsutism, insulin resistance, hormonal imbalances, and things like that. And finally, what type of calories are you consuming? Are you consuming refined calories? Are you consuming off-the-shelf calories? While these bring in a lot of insulin spikes and add a lot to the weight gain, but they also contribute to the low-grade inflammation which is present with obesity and adipose cells. So if people can take care of their sleep cycle, maintain a proper fixed sleep cycle, reduce the calorie intake, especially those coming from refined and off-the-shelf quick fixes, fast foods, sodas, sweet drinks, and sugar essentially, I think that will significantly improve their overall condition. And exercise, any kind of exercise. When I talk to people exercise, they say that no, I'm busy the whole day. I'm running between the offices, I climb steps, I walk about 8,000 steps throughout the day. No, that's absolutely fine. But what is important is when you're doing all these things, there's this component of stress involved in doing that. You have to reach an office within a stipulated time. Suppose you're running from your metro station to the office, it's about a kilometer. Understood, your body is getting some sort of exercise, but it is under the influence of cortisol, which is a stress hormone, which again increases the vicious cycle. So what I tell them is the best thing to do is at least do a walk. Leave your phone and all your worries at home. Take a walk for about 3,000 steps per day. That is the simplest and most effective exercise that can be seen because that involves a lot of the larger muscles in the body. Because the thigh muscles, the gluteal muscles, the back muscles, and that will indirectly lead to expenditure of energy, reduction in weight, and improve insulin sensitivity. The other component, what I was mentioning, was the pharmacology treatment to it. So before we get into the pharmacology, what we have to be mindful is that we'll have to rule out a couple of conditions. One is something known as a congenital adrenal hyperplasia. So we have to try and rule out what are the other conditions that can cause an increase in androgens, right? So congenital adrenal hyperplasia is one. And also we'll have to be mindful that if women are on oral contraceptives, then the tests which we do for PCOS will get masked or will not be represented accurately. So having said that, so if you look at the pharmacology can be broadly two types. One is a cosmetic, the other one is more of a therapeutic kind of. So what is the cosmetic approach to it? The cosmetic approach is the symptoms of hirsutism and the voice change. Voice change is something which unfortunately we will not be able to do anything much on a short-term gain, but in the longer term that may come back to feminine voice eventually. But if you look at the acne or hair loss or hair growth on the face and other parts of the body, then it's a purely cosmetic approach which you need to do. We follow the advice of the skin specialist to use retinoids or local applications for acne. For hair loss, the hair which has been lost, it's difficult to regain. But if there's minimal hair loss, then you can at least further stop that getting lost. For instance, we can use drugs which are anti-androgenic in nature. For instance, spironolactone is one, which is a loop diuretic, which is a potassium-sparing diuretic, and that can be used. But we have to be mindful that when we are using loop diuretics like spironolactone, frequently check for hyperkalemia, which can happen in cases. The other two drugs which we generally recommend is, one is the combined oral contraceptive pills. Now, what this oral contraceptive pills will do is it's basically overriding the body's system of hormone production. And we put people on oral contraceptive pills for a minimum of 3-month duration. It contains a 21 days OCPs and then 9 days of withdrawal bleeding, which will happen. So the induction of bleeding and this thing, while complementary, will not be substituted for what I described about food, sleep, and exercise. And thirdly, which is off the shelf, which is not a great significant, but it will help to some extent, is insulin sensitizers. So we would like to put the patient on metformin depending on their body weight as to how much we could try and do this. And finally, the elephant in the room. Sorry for the analogy, but it's the weight, right? What are the drugs which will help in reduction of the weight? There are a few drugs which are approved by FDA and which are also followed in India. Some of them are which act on the central nervous system, like topiramate can be used, right? And in varying doses, start with a slow dose, but it has got a side effect which can lead to increased intraocular pressure, so periodic monitoring is required. The other one is if persons, like I said, depending on their diet, if they're consuming a high amount of fat content, then drugs like pancreatic lipase inhibitors or listat could be used. But again, that's complementary. But the biggest gain, what we have in terms of the most powerful drug for the weight loss is, by and large, the GLP-1 analogs. So the GLP-1 analog will address diabetes, but it will also importantly increase insulin sensitivity, periodic release of insulin of whatever is left, and significantly weight loss. So even a 5 to 7% weight loss, what we have seen generally is that with 5 to 7% of weight loss in a woman, 80% of them regain their ovulatory cycles. So whether you give them oral contraceptive pills or not, but if they're able to manage their diet, their sleep, their stress and exercise, and definitely lose the weight, then PCOS by and large can be considered quote unquote cured.
Yeah. So thank you for actually giving a brief idea of entire non-pharmacological as well as pharmacological management that can be taken for PCOS. And I think along with pharmacological, obviously lifestyle interventions also plays a big role, as you also mentioned. So now coming to the next question, long-term data clearly shows that women with PCOS have a higher risk of developing type 2 diabetes or non-alcoholic fatty liver disease and cardiovascular disease as well. So for clinicians listening in, what would you recommend in terms of surveillance intervals and preventive strategies?
Right. So before we go there, let me reiterate the nexus between these two. Like I said, luteinizing hormone will cause androgen production. These androgens will lead to increased insulin resistance, and insulin resistance will cause diabetes or at very high risk of developing type 2 diabetes mellitus. There's hyperinsulinemia, which is per se again leading to a lot of weight gain, diabetes. So you look at this from the perspective of diabetes management, right? Well, if somebody has developed diabetes or somebody is yet to develop diabetes but have some sort of dysglycemia. So people who have dysglycemia, obviously the best way to approach that is all the lifestyle factors which I did mention previously to do that. For people who already have established diabetes, because there's also dyslipidemia associated with it, it invariably lead to hepatic steatosis for other reasons, alcoholic, non-alcoholic, and other metabolic hepatic steatosis is what we generally call it. So the routine follow-up cycle related to diabetes management is what we would recommend for somebody who is non-diabetic, whether with PCOS or without PCOS. That's if they have a HbA1c of about 10, then we'd keep a target of at least 7 to start with. And do a month when we start the medications in the first phase, then we would like to see them through for about a month's time. Get all the routine tests done again, like HbA1c, their fasting, postprandial, lipid profile to understand all those things. Once we have reached a target of about 7 and below HbA1c, then we can keep this follow-up at once every 6 months. We can get all the tests repeated. What will not help is getting the hormones retested again and again. Yes, so it is a deranged problem, but it is a possibility that it can be set right through all the lifestyle and dietary interventions. And once that is done with weight loss, the PCOS symptoms cease to exist.
Right. Thank you for sharing that, doctor. Now, finally, one of the biggest challenges that I'm aware of in PCOS management is delayed diagnosis and fragmented care. So, from your perspective, what would be an ideal multidisciplinary model for PCOS management to look like in a tertiary care or a hospital setting?
So let me try and phrase this in a slightly different approach. One is, we know it's definitely fragmented because in the beginning of this podcast you did mention that till recently people thought PCOD was more of a gynecological related issue, not a metabolic one. So now it's slowly getting realized. So people, especially the providers, have to be more aware of this. So having said that, I'll rather have a more of a client or patient oriented approach to this. So one is people should know what PCOS is, that they should have access to validated and standardized information. So what do I mean by that? Is not heavy literature or textbook kind of thing. Basically simple, like if there is an adolescent girl or a very young woman who has missed her period consecutively for 3 months and is not on steroids or is not, is not on oral contraceptives and is not pregnant, then this is definitely a cue for people to understand that they need to get tested. So the awareness should come from within. Plus, if they're gaining weight, right? So this weight gain, lethargy, all these things have to be ruled out. And any abnormalities in the period cycle should be the first trigger for approaching of this. Now, once they land in the hospital, because it's a girl or an adolescent woman, they obviously go to the gynecologist. And the gynecologist will do all those tests. And by default, once diagnosed, their approach is to have the patient started on oral contraceptive pills. So some do mention about lifestyle changes and the need to manage diabetes or hyperglycemia, dysglycemia, all those things. But there is a need to have a team approach to this. Definitely the gynecologist is at the center point, but then there's a need for other people to get involved, not necessarily an endocrinologist, but at least an internal medicine person, a physician by nature, and a nutritionist or a lifestyle coach. Plus, what will help also is that forming small support groups within the women, within their friends group, or within the people whom they know, that can be facilitated by the clinician, and they can support each other on those parameters. Since it's important to understand that this has become a major of a public health problem, what is also important is to understand that this condition does not stay in isolation to the body alone. It does affect the mood and the mind and the thought process of the woman eventually. So it might lead to depression, anxiety, which is again, continuing to weight gain and all those things. So even in the mental health clinics or counselors or psychologists, especially in colleges, where a girl seeks for her mood disorder, then or an anxiety or a depression shortly, then that can be the tip of the iceberg where the counselor can dig a little deeper to understand about her period cycle and the frequency of that cycle. Then that leads to a medical diagnosis. So everybody at the front end who is at the facing the patient should be aware of this, that a disturbed cycle for more than 3 months is definitely a starting point for people to follow.
And I think it is very necessary for the people to share that awareness or have that awareness also regarding the hierarchy or the teams involved for PCOS. So it's really important for people, general audience also to know that.
Yeah, multidisciplinary approach essentially.
Yes, it's really important, Doctor. So now, Doctor, as we wrap up this session, thank you so much once again for sharing this insight. And it is clear that, PCOS is not just a women's health issue, but a lifelong metabolic condition that, deserves structured and comprehensive care altogether. So thank you for sharing that with us today.
Yeah, absolutely. It's a pleasure, and any day I'm happy to be contributing.
Thank you, Doctor. And to our listeners, thank you for tuning into this episode. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay curious, stay informed, and keep making a difference in healthcare.